to the Nuts and Bolts series. So today I'm going to be talking to Dr. Janardhan Selathurai, who's a orthopedic F1, which has come to the end of his placement. And we're going to be talking about how he found his placement and what he thought of orthopedics. So to begin with, Janardhan, welcome.
Thank you very much. Appreciate you inviting me as well. I'm good. I've been enjoying the Easter break. So yeah, spending it with the family and just chilling out a bit.
Awesome. So let's get into it. So to start off with, let's go back to medical school or before you started your orthopedic placement. So you're currently in orthopedic FY1 and you've come to the end of your orthopedic placement. What did you hear about orthopedics before you started?
Yeah, so this is my second F1 rotation, so I haven't got a lot of rotations to compare it against. And the only other thing where I've had some sort of orthopedic exposure was during one of my blocks at Warwick Med School. So that's where I went. And under the MSK block, I actually came to Coventry Hospital. That's where I had it as well. So I worked with the team that I'm working with right now, but as a medical student at the time. And so when we came through, a lot of it was just coming into the trauma meetings, the fracture clinics and so on as a med student. And at the time, a lot of it just went over my head, especially in the trauma meetings. And I guess as a med student, you already feel like you're a fly on the wall in a lot of scenarios. And seeing how busy trauma and orthopedics was at the time as a med student, it was difficult to get involved. So I guess I had that sort of expectation of almost like I sort of came in expecting that maybe the consultants and the rest of the team, there might be more of a disconnect, essentially. That's one of the things I assumed. And then also with some of my friends who have had a TNO rotation, when I've talked to them, they've talked about how they've been essentially battered on the wards. That's the way they described it, because the cover for them was very little. And essentially, you're just managing all of the patients on the ward. There's the medical issues and how you need to know all of the medical side of it. And for me, I was just thought, how the hell am I going to manage all of the medical issues? I already feel very like, I'm only in my sort of earlier stages of training. And thinking about the medical management, I was just like, that might be quite difficult. So there was that sort of expectation that I came in with. And then also, yeah, I mean, I hate to kind of admit it as well, but you know the stereotypes that you hear about surgeons and the TNO surgeons, for example, and how, it's all about, fixing them, getting people out of the hospital. And so these are the kind of expectations that I came with into the rotation, but I was actually very pleasantly surprised. I don't know if it's just unique to Coventry Hospital or not, but, with the different teams that we have, there seemed to be such a cohesion with everyone. And there was actually a lot of senior support. A lot of the consultants, they're on WhatsApp. So, they were happy with me messaging them at times, just, getting them to double check an x-ray, for example, or just getting further advice about how to manage patients. So I never felt like I was out of my depth. There was always that continuous support. The other side of it was the workload that I was obviously a bit wary about coming in as well. But there was enough support once again with the sort of advanced nurse practitioners, and then who are obviously like with years of experience. They pretty much run the show at Coventry Hospital. So that side of it, and then also the different teams, meant that it seemed to be really well organized. Yes, as the F1, the way it worked at Coventry Hospital was that I was always with the team that was on call during the weekend. So I always had a long list of patients to deal with, but it never felt overwhelming at any time because there was enough support. And then, like I said, the most surprising aspect for me was just like I didn't want to come in with any prejudices, so I was open. But actually, all of the surgeons, everyone who has worked with, who I've worked with, they've all been lovely to patients, and they've actually dedicated a lot of time towards them. And what I found was that a lot of patients who we did see were either the elderly or people who have had sort of like traumatic injuries that would have led to a whole change in their lifestyle. So you can imagine that psychologically there's a lot of support that they need as well. And seeing that the surgeons were willing to give them the time and actually listen to the concerns and try and give them that support was actually really refreshing to see, and it completely changed my sort of outlook on TNO.
Sure. So, I mean, it sounds like you had a positive experience, but why do you think TNO has that reputation for, people being sort of battered and brash and, not dedicating time to the patients? Have you heard that from your friends before you started, and where do you think that comes from?
I'm not entirely too sure where it comes from, but like I said, I think, so if I address the side of like, people being just overworked, I think it could have been just individual to my friends who were in those hospitals. It could just be that the cover that they had wasn't adequate, or maybe the way that the department wasn't organized. It could be down to organizational issues, I think,
Yeah.
less so than maybe potentially, I guess, like the individuals that they have there. Regarding the sort of like the brash attitudes, I guess, that people have an assumption of when it comes to surgeons is, based upon my sort of like previous rotation I was on as well, there's almost like when it comes to the surgery, it's a very, I mean, I even found that there was a big difference in terms of the surgery. There's a lot of like brute force that goes into it. And there's a lot of, it felt like DT at times, and I love DT. And, you can imagine that the sort of people that it attracts were going to be a bit more different, or the stuff that we talk about are like nails, plates, and, some people kind of, I mean, I'm not saying this is what I see it as now. It's just, you see it as, some people have described it as the carpentry of medicine. And so I think with those sort of stereotypes, it's just, I guess, what people build up an image of. And because it just requires a bit more force at times, maybe to like, bang in a nail, it doesn't necessarily mean that that's the approach that you're going to take towards patients and people. But I think it could be those things that people make an assumption of. But, I think if I go forward now talking about TNO and my experiences of it, like it's going to be completely different to what a lot of my friends have shared.
I like that comparison to DT. I mean, some of our more mature people who might be listening, DT refers to design technology, if I've got that right, which was a subject that some of us did in school, making post-it note holders and things like that, which takes me back actually. But so let's move on. Let's talk about your placement now. So you've had 4 months in orthopedics and orthogeriatrics, and if you could just talk to us about what your day-to-day schedule was like. What were you doing?
Yeah, so I think first of all, it's important to note that my rotation specifically here is going to be very different to most people's orthopedic rotation because it's a supernumerary post. So what a supernumerary post essentially entails, it's a Monday to Friday. For me, it was 7:30 to 3:30, so an 8-hour day. And I didn't have any on-calls, nothing like that, which is quite different to the common F1, F2 orthopedic rotation. They usually have on-calls, weekend shifts and so on as well to do. So my typical day and week was pretty much the same. Like I mentioned before, the way it works at Coventry is that there's 4 teams who are covering the on-call. There were 4 teams, and therefore each team was the on-call team for that weekend. And as the F1, I'd always rotate between the teams and support the one who were essentially on call over that weekend because I'm seen as a bonus member. So, the department, the hospital works fine, whether I'm there or whether I'm not there.
I like that description of F1 as a bonus member of the team, like an extra.
Like I said, for the supernumerary post here at Coventry, that's the way it worked at least anyway. So on the Monday, I'd do the post-take ward round. So it tends to be a much busier morning. You go around clerking in the new patients or seeing them with the consultant. And there's a lot of jobs that you accumulate. And by the end of the week, you almost try and challenge yourself to see how many people you can get in and out of the hospital. So a lot of it basically for me as the F1 was predominantly ward cover, a lot of the ward related jobs. And then depending on how I managed to handle that, or if it was a quieter day, it meant that I could either join, depending on which team I was. If it was, let's say, I can go on the on calls as well. So there were a couple of times when I've asked the senior house officer or like the registrar who were on call to just give me a bleep whenever a trauma case came through, so I can go and see what that was like. So I can join the on call, or I can also. I also had a chance to go to theatres a couple of times as well, depending on how ward cover was. But like I said, for me, the priority, and I understood that my role was essentially providing that ward cover. On Mondays, we always had teaching that was peer-led teaching. We also had the chance to do teaching ourselves as well within the department, which was good fun. And actually, a lot of seeing as it was sort of taught by peers, it's a really friendly environment. And then Fridays tends to be also quite busy as well at times, because that's when you're preparing all of your patients for like the weekend reviews, and sort of wrapping up bits and bobs there. So that's how the overall week looked like. But the way my day usually looked like is, like I said, in the morning, it's a lot of the ward cover, trying to get through the jobs. And then in the afternoon, after lunch, it tends to be essentially chasing up bloods, trying to see if there's anything that needs to be actioned from the jobs in the in the morning, and sometimes it's sort of like preparing for the day ahead by sort of requesting bloods, updating your list, prepping your TTOs and discharge summaries.
And so if you're doing your ward round in the morning, if you had a query or a question, would you be going to SHOs, registrars, consultants straight away? How did that work?
So what was different for me on this rotation in comparison to my previous one is that the ward round, like I was encouraged to go and see patients myself. I remember on the first day when I came, and the team that I was with, they allocated me patients to go see, and I was like, I've never seen a patient by myself, because in the previous rotation, we went around with the registrar. So you always felt like, they were the ones who did most of the consultation and where they're documenting what's happening, making a list of all of the jobs. Whereas here, I had to go see the patients, I had to go examine them, I had to then document and then had to action and essentially relay all of this. So I was, I felt really out of depth on my sort of first couple of weeks, I guess, seeing patients, because there was always that worry of, have I missed something? Is this normal? You don't know what is normal, what's not normal, what the normal progression of a patient is like as well. So I guess with that sort of like ward round side of it in the morning, if I did then have any questions, I guess once I've seen all of the patients, I had the advanced nurse practitioners to talk to, because they've had years of experience, they would have seen patients, they know what to do. I've also then had the sort of like SHOs in the team that I could contact, and they were the ones who I normally went to first to try and get like a second eye if I needed to. Sometimes the registrars were also available if they were on call or if they were around, and with the consultant side of it, depending on which team, they do it differently. Some teams had a consultant coming, they took turns in terms of which consultant came for that day to just quickly do a board round, I guess, talking through the patients, flagging up anyone that was concerned. With another team, for example, every Wednesday morning it was a consultant-led ward round, so they got to see all of their patients. And like I said, if I did have any questions that needed to be flagged up towards a consultant, which wasn't common, to be honest. I'm trying to think about scenarios where I've had to flag it up to a consultant over a registrar. I guess it would be sort of like, usually if we needed to get an X-ray reviewed and to try and decide what the overall management is. So there's been scenarios where a patient's coming with a neck and femur fracture. Depending on the X-rays in the trauma meeting, there was a discussion about managing them initially conservatively, then trying to see what sort of physio input does and how they get on. And then having that sort of discussion to then see, okay, are we going to continue conservatively or do we need to take them to theatres? Those were the sort of decisions where I've had to get in touch with a consultant for.
Okay, so there's kind of big decisions where you need someone really senior, the top boss basically making that call.
Yeah, but I mean, from an F1 level, in terms of the stuff that I was managing, a lot of the queries could be helped with either, the pharmacy input, either the advanced nurse practitioners or the SHOs. I didn't really have to flag up a lot of the stuff that I was seeing to the consultants.
Fine. And you were dealing with most of the medical management of these orthopedic patients on the wards. You weren't, were you seen as the person to deal with all of this stuff, or could you get help on that medical side, which sometimes orthopods aren't famously well for getting involved with?
So because all of the patients I had to do was ward cover, is that essentially sometimes you deal with the pre-op side of it, but most of the pre-op stuff would have been done whilst they're in ED, when they've been admitted at that point. Or they go straight into theatres. The turnover was really quick. So most of the people that I saw were post-op. So with the post-op recovery, there weren't that many sort of like, I guess, medical issues that I'd have to continuously deal with because, most of the people who came in were elderly. So they would have had some sort of medical sort of like they've already had a lot of comorbidities that are being already managed, and you just continue them. And sometimes you just deal with like the fluid balance, sometimes dehydration issues, electrolyte imbalances, and so on. And those things was like I had enough support, like I said, from the advanced nurse practitioners and also the other more senior doctors around as well. So I didn't feel too out of depth. Earlier as well, prior to the sort of the COVID spike on my rotation, there was also in the afternoon the ortho Jerry's ward round. So that was essentially for, I've forgotten the age cutoff now, I think it's over 65, and also neck and femur fractures. There tends to be a geriatrician who came through, who would take a look at all of the medical issues or anything that we specifically flagged up from the orthopedic team that we wanted a sort of medical doctor's input on as well. And common issues that we took a look at would be sort of like blood pressure, issues with managing blood pressures, or maybe electrolyte imbalances, or sometimes, patients may have developed like a TIA or a stroke whilst during their in-stay, and just getting them to cast a second eye and further optimize that care, or even sort of cardiac related issues. Those were the common sort of things that came about. So even then, in that moment, in the afternoon ward rounds with the consultant, you felt like you were well supported. Yes, in the past couple of months, there hasn't been the ortho-geri side of it because they've been just really swamped on their geriatric side. But even then, some of the medical things that we were optimizing that were quite, that we were able to pick up now is like, the vitamin D levels, the sort of calcium levels, and just giving them the bone protection and so on. And once again, that is more with the elderly population.
You touched on it a bit. So you said the last couple of months, the geriatricians haven't been there as much because they've been swamped. Can you just tell us how things have changed for you during COVID with your orthopedic placement? Have things been different?
Yeah, of course. I think, once again, this is going to vary hospital to hospital and how they all approached it. So I know in some hospitals, for example, the F1s, F2s and other doctors got redeployed to areas where they needed more COVID support. The way it worked here in Coventry is that there were 2 wards, and one of the ward ended up becoming more of a predominant sort of like patients with COVID from all over the hospital, outliers essentially being admitted there. And then the other ward was still our sort of, orthopedic patients. And so the way it worked for us is in the mornings we'd see, our priority would obviously still be with our orthopedic patients. So we saw them. And once we'd done that, we then went over to the COVID side of it and gave the sort of medical team who were already based there, which was just essentially a consultant and a registrar, further support. So we were acting as, the F1s and the senior house officers, giving them the support. And because we were sort of doing our fair share of input into the COVID patients, we didn't get redeployed. We were there managing our orthopedic patients and the COVID patients. So I guess the workload was a lot higher in that moment, because not only are you seeing your own patient, you're seeing the medical outliers on there as well. The other changes that COVID had is the ortho-geri's ward round stopped happening. That was in the afternoon. And that was actually quite useful for, like I said, trying to get a medical opinion for some of the patients that we felt like we needed a med reg or med consultant to come and review. And because we had that sort of almost, that exchange with the ortho-geris, it was easier to get medical input and medical advice than it would be to try and get a medical registrar on call to come and review a patient. So we missed out on that.
But did you feel that did you feel that you struggled when you didn't have the ortho-geriatric consultants because they were, busy treating COVID patients? Or did you feel like that by that time in your placement that, you'd kind of got used to how to manage these patients?
So personally, I'm not trying to downplay the role of the ortho-geriatrics and what input they had, because there were complex issues that, the consultant's input was really helpful for. Like I said, when we were kind of optimizing any patients who have had like a TIA, stroke, or any cardiac related events. But the number of people who had that was obviously a lot lower than the rest of the patients. With the majority of the patients we saw in the ortho-geriatric ward round, it was essentially optimizing their sort of vitamin D supplements and their levels, taking a look at that, and also offering, like, assessing patients and seeing what their bone protection and what sort of stuff that they needed there. Because, a lot of the neck of femur fractures that they saw who came in, essentially those issues had happened because, as you get older, your bones get weaker and a fall can result in a fracture. So it's kind of optimizing all of that. But you pick up on all of the things that they ask, the questions that they ask, the sort of medication that are then offered. You sort of pick that up by doing those ortho-geri ward rounds. And so I felt quite confident to be able to, to sort of manage that in the later stages of that rotation.
Fine. Okay. And I guess thinking back over your last 4 months now, you're rotating next week. Is that right?
Yeah. So last day's on Tuesday, and I'm going to sorely miss. Yeah, I'm going to miss being part of the orthopedic team. But then, new rotation on Wednesday.
I haven't paid him to say that, guys, as well. You generally feel that way, right? So I guess thinking back over your 4-month placement, I would ask you, what would you say you've enjoyed the most first?
Oh, definitely the team cohesion. I think I felt like as the because I knew I was going to be the only F1. So I felt like, am I going to feel like I'm left out of the team, especially being so junior in my training? But I felt like I was, I know that sometimes the roles and the jobs that I do aren't going to be the most pivotal, and it's something that everyone else can do. But, I just felt really involved with the team. And the interactions with a lot of the patients that I've had, especially the elderly patients, I've had sort of like relationship advice, I've had personal life advice from patients, I've had just good banter with all of them. And, you know, those interactions has been something that I'm going to remember. The teaching sessions have been like great, because a lot of it hasn't just been theoretical teaching, it's also been practical teaching. So knowing how to use lag screws, plaster applications, and it just felt like, yeah, you don't always get a lot of practical teaching. So the teaching in itself was different. And as with any other rotations, I've also enjoyed the sort of rapport and the relationships that you build with the nursing team and the staff in that department. And I think that's the thing that I always get frustrated by, which is, you know, towards the end of your rotation, you feel like you're part of a team, you look forward to going in, and you enjoy those interactions, but then you then have to now change over, build new relationships, get on with new people again. And I guess as the F1, like once again, it's quite unique as a supernumerary position. Yes, I got a pay hit because I was working less hours, but I loved the work-life balance. Especially during the winter periods when there wasn't much daylight, it felt like there was still enough time for me to do everything I wanted to do in the evenings. And I really I'm someone who wakes up early, and I like an early start anyway. So with the orthopedic team, you start the trauma meeting starts at 7:30, you start your ward rounds around 8 o'clock. So I love the fact that we started early, finished sort of earlier, and just the pace of it all was great. But I think if there's one thing that I really took away from it all that really stood out, is just the sort of transformation that you can see in patients, and you know how quickly you turn over patients and how much of an impact you can have on their lives. That I think is what's quite unique to TNO at the moment. But once again, I guess the flip side of all of that is with the sort of injuries that people come in with, the impact it has on their life can also lead to quite difficult conversations. So there's been scenarios where patients have had to have amputations, or scenarios where, you know, people who are quite active with their day-to-day, or their job requires them to be quite active, like builders, engineers, and using step ladders and so on. The impact that these injuries then have on their life going forward, and seeing patients having to really deal with that and take that in and breaking that bad news, that can also be quite taxing emotionally at times. So that's been one of the challenges, I guess, of the role. But I'm also grateful for it, because through those interactions, you practice that skill. Because in med school, yeah, we get taught the whole spikes model. This is how you break bad news, and you understand it on a sort of rational, practical, like on a theoretical level. But actually applying that, you realize each patient, like, you know, it's a very individual approach you need to take. And it's just one of those things that the more you do, the better you become at it. So it's been a good placement to actually practice those softer skills as well, which not a lot of people would think about straight away. And I guess and it's just the social issues that can sometimes keep patients in, because a lot of people come from care homes and trying to get them packages of care before they get discharged, and in those moments you feel really helpless in terms of the input that you can have.
Yeah, no, I think that's very, very valid. I mean, I think the biggest question from everything you've said is, what was the relationship advice you were given from patients? And did you take it?
So, you know, some patients, for example, we're talking about for their years of their extended marriage, they were talking about your own space is very important. The other, some of the patients also gave me the advice of how, what's it called? Sometimes just committing early and just seeing no other options is one of the best way to take a look at it. How, you know, decision paralysis could be one of the things, the choice paradox, right? Like how that can also play on people's mind. And yeah, like had really interesting advice and conversations around that.
Fine. So low key, the moral is that, you know, you can get some relationship advice, you can get therapy. Orthopedic department is more than just seing patients and treating them medically.
Of course. Yeah, because I think that's the thing, isn't it? Like, I guess as a society on the whole, we don't always value the elderly. I mean, I know these can be quite direct, harsh words, but I think in comparison to a lot of the other cultures and the way I've seen, so for example, my roots are from Sri Lanka, and my grandparents and so on, they're essentially the core component of our families. That's the way we see them. And sometimes I guess here, there's not a certain level of, I wouldn't say, I guess loneliness, for example, is a huge thing that they talk about, right? And so that's something that a lot of patients have talked about here as well.
I guess it's been amplified over the last year or so, especially with COVID being, being locked up and, locked down essentially. But yeah, I get what you mean, where it's in kind of cultures, from Pakistan as well, that you have those senior members of the family at the center and the core of the family.
Yeah.
And you do over here as well, but sometimes you can see that loneliness developing, when people are, living by themselves. I guess turning that question on its head, asking you about what you enjoyed during your placement, what would you say the biggest challenges were?
So I think I touched upon a few of those as well. For me, sometimes the challenges, like I said, was having conversations where, in the ward round, for example, when we quickly see patients, we try and just take a look at it from the medical side of it, of what they need. And then afterwards, going back to further delve into conversations, that could be sometimes both emotionally draining, but also in those moments, I've also just been very conscious of the things that I'm saying, the sort of conversations, and trying to give them the best support. So, for example, there's been quite a lot of suicide attempts. Patients who have had suicide attempts coming through, and then just having those conversations and just trying to see how they're getting on with it. The number of conversations I've actually had with elderly members who, I'd go around on the ward round and, see how they're getting on. And I'd say the phrase that I've heard the most is with elderly patients is them saying, I don't feel like going on any further. And that's usually because of the pain that they have, or just being in hospital, really struggling to actually recover post-operatively and almost giving up. And that mindset of trying to encourage people to not give up and to keep fighting, that is so pivotal for recovery. I've seen that in the patients. The patients who tend to do well after surgery or even before surgery are the ones who take more of an optimistic outlook on things, who want to give it their best. And actually having those conversations can be quite challenging, but I'm glad I've had those conversations because I feel more comfortable having those going forward.
100%. I mean, I agree. It's just, I think that during, when we work on the wards, when I was on the ward, certainly you see a patient at one point during their story, their life of, when they're at, their lowest potentially, when they've had a fracture or they need some input from us. But these challenging conversations you're talking about, we can start them or certainly continue them, but then at some point we discharge the patient and then we don't really know what happens to them unless you see them in the clinic in several weeks' time, where we're kind of more focused on obviously dealing with their physical fractures or their recovery from that viewpoint. We sometimes, you don't really know how that patient got on 1-2 years down the line, which can be difficult at times because you don't know what the outcome was, the overall outcome for that patient. Mentally, especially during the lockdown and COVID, where we've had less people coming into hospital. I've noticed that particularly.
Yeah, but I guess the silver lining with that as well, though, is you can also try and see how you never know the impacts of what a few positive interactions can also have in the long run.
Yeah.
So that's the way I've always tried to see it before I do the ward rounds, is that, yes, I know I'm only going to be there for the acute stay, for a short stay of their life, essentially, of when they've come through, but to never underestimate and sort of undervalue the impact of positive conversations and what that can have going forward for patients.
Yeah, no, I 100% agree. So I think if you could tell yourself something a year ago, even 4 months ago, before you started this placement, what advice would you give yourself, or indeed to anyone who's going to be doing an orthopedic placement in F1?
There's quite a lot of things that I think that I sort of like brainstormed before this. But if I went in terms of order of priority, one of the things that I would have it's quite easy in terms of that doesn't take much time, but yields a lot of output, is understanding pain control and also laxatives. I know it sounds really basic, but there's certain laxatives, for example, that are more effective. There's also certain pain control, for example, that are more effective. So understanding the whole, like the WHO pain ladder, yes, you've got all of that, but then there's other medications that I wasn't aware of that we prescribed quite oftenly. So for example, the morphine sulfate modified release, Zomorph, on the 12-hourly, that's been quite useful for the pain relief side of it as background pain. And then also with like the laxatives, the different ones that you can use. So if I was to if I was to give myself a list of the ones most commonly, correct me if I'm wrong here, by the way, Arham, I know you've got a lot more of the
it's been a long time since I was on the wards, I can tell you that.
But I've noticed that, for example, Senna, that's always written without any issues because it doesn't really cause any issues.
The Senna Movicol Dio is a favorite, I think, in all orthopedic departments and probably across the hospital up and down the country.
Yeah, exactly. So like the laxative side of it, and how important it is to actually get that started early, because a lot of the patients, once they've recovered post-operatively, the thing that's held them up is not having opened their bowels. It sounds so trivial, but that is a big thing actually, because it can also have further impact in terms of bowel obstructions and the consequences of that, for example. So actually getting on top of laxatives and pain is a huge thing, because like I said, with the patients who felt like they couldn't get on any, who couldn't go any longer, a lot of it was because of the pain. So getting on top of the pain and the laxatives early on, that's a big thing. Understanding, for example, a checklist of the things that you want to know as the F1, I guess. So it's like before they've been admitted, or I mean, before they've had the operation, knowing whether they've had their consent form, whether they've had valid group and saves, whether they've had a DNA CPR form. Those are things that you can almost have as a mental checklist to flag up to the rest of the team if you need to get those things done. And then I guess post-operatively, or even thinking about their sort of range of motion with their sort of whichever limb that's been worked upon, the weight bearing status, thinking about the follow-up, thinking about I guess, like I said, the vitamin D's and the bone optimization side of it, thinking whether you need to get a dietetics referral in as well, because diet plays a huge role in obviously their recovery. So trying to break it into pre-op, sort of during in stay, and then also post-op management, I think that was really helpful for me. Other things that I would have wanted to read up a bit more 4 months ago would have been the fluid balance, the electrolyte imbalances, how to correct those, because one of the things that I saw the most was just chronic hypernatremia, or like hypernatremia following on from surgery, and sort of managing that. Also with Coventry Hospital, I don't know how it is in other ones, the spinal team, for example, came on sometimes I had to give cover for the spinal orthopedic team as well. So knowing neurological exams, the dermatomes, the sort of like, that was an exam that I wish I kind of learned a bit more about as well.
All that stuff in med school that everyone just parks to one side after doing the exam.
Exactly, yeah, the stuff that we kind of overlook. And I guess if there was one thing that I had to tell myself on day one when I was bricking myself, going to see my first patient by myself, is just get stuck in, because if you are worried about anything, you can always get another senior member to come and review the patient. B, don't forget that it is a person at the end of the day that you can just have a general conversation with and do all of these things in between. And I guess if there was a simple framework for me to use, I would have first of all, most of the, like, I'm not saying this is everything, but there's the main key points that I'm taking a look at is their sort of fluid balance, whether they're dehydrated or whether they're, taking in enough urine output. And then sort of whether they're eating and drinking, how their pain's managed, when they've last opened their bowels. And with the pain side of it, really getting a score out of 10. I know it sounds like a silly question that we always ask in our histories, but that's actually really helpful to try and see objectively whether their actual medication needs to be altered or not. So the pain focus, and then when we're examining, because this is the bit that really I was so worried about, the examination side of it, is first of all taking a look at the wound and the dressing. And a word that I learned was strike through. So strike through being how much sort of bleeding or so on that we see, and writing that as a percentage idea of whether there's any bleeding from the site, because that's essentially what we're taking a look for. Erythema, bruising, any sort of signs of infection around the wound. So that kind of looks at the wound, and then taking a look for calves. So if we're talking about neck or femur, let's just run with that then. Feeling for their calves, seeing if it's soft, non-tender, because you're trying to rule out any signs of like DVTs, and sort of seeing if they're neurovascularly intact, and then also seeing how they're progressing with the sort of physios. So once you've done that, working with the other teams to find out how they're progressing with the physios, how long it would be before they think they're ready for discharge, and then also working with the IDT team, so integrated discharge team, I think. So they're the ones who find out appropriate packages of care, social, like, care home placements and so on. So working with them as well to find out where this patient is.
Well, that's very, very comprehensive. I think we should probably get you back to talk to all the orthopedic F1s coming in now about how to do the placement, because that was super, super comprehensive. So I guess you'd break it up into the medical management, your day-to-day job, and then also kind of more generally treating that patient as a patient and a person that you can actually just talk to and have a chat with, as well as helping them out and managing them.
Yeah, which sounds like really obvious advice, but I think it's sometimes also helpful to remind ourselves of that, because I think, as med students, I noticed that I did that a lot more, but then as soon as you get the title doctor in front of you, you feel like, personally for me anyway, you get so caught up on the medical aspect of it all.
You're so task focused, you just go and do the task and then then get out. But yeah, no, I 100% agree, because you've got so many jobs to do that you just want to kind of get through your jobs as quickly as possible. But
Yeah,
sometimes it's probably, more impactful to just chat with the patient.
exactly.
Awesome. Well, thank you so much.
No worries, no worries.
Is there anything, kind of any closing statements or anything else you want to say to anyone doing your job, or how you found your time?
I think there's only so much pre-planning and sort of preparation you can do. I don't know if that's the lazy side of me saying that, or the part of me that doesn't want to prepare for the next rotation. But I think the quickest way, or the biggest bang for buck, is actually just getting stuck in, learning on the job, and just being open and accepting of the fact that you're not going to know it all. Because I think as medics, we want to know it all as much as we can. We base and the idea of uncertainty or the unknown, for example, is something that not only frightens medics, but just us as humans, right? Like the idea of the unknown. But if we become comfortable with that, and if we accept that we're going to be sort of like here to learn, and having that sort of like, just because we finished med school, it doesn't mean that we now need to know everything sort of attitude. I think that's the number one key. And it's actually helpful for me to remind myself now, because I have been feeling a bit apprehensive about starting the next rotation, because I don't know what to expect. I feel like I'm going to be so out of my depth, but actually it's just F1 and F2 is still training. And I think it's like those rotations are there for you to learn from. And to just kind of back yourself, know that you're going to have enough support, and that there isn't a silly question to ask. And yeah, and to have fun. I think that's the other thing that we sometimes forget, especially with the pandemic and everything that's been going on. Talking about work and so on can be actually, like, we think it's, we forget the aspect of having fun, and you can quite easily have that with the interactions you have with the teams that you have around you. And to enjoy it all, I guess, which sounds really cliche. I feel like that's how everyone wraps it up.
Well, it's nice to finish on a cliched, note, just to kind of bring everything together. But no, honestly, I think that's really, really suitable and solid advice, and something that I know that even I would have benefited from when I did orthopedics, my first orthopedic job as well, several years ago. So I just want to say thank you very, very much, Janardhan. I really, really appreciate you giving up your time. And I'm sure you've helped lots of people who are going to be orthopedic F1s or work in the orthopedic department in general. So I really appreciate your time. Thanks a lot.
Yeah, and thank you for inviting me as well, because I think, what I really enjoyed about today's conversation is that it's just given me a moment to reflect on the past 4 months and actually been like, I've really enjoyed it. And I'm looking forward to the next rotation, and all the best with all of the stuff that you're doing as well, man. Like the teaching that you provided. I remember seeing you on one of our teaching programs from before, and I was like, is this the same Arham that I've seen? And then also you've obviously got your Instagram page where you're doing a lot of orthopedic teaching, and right now you've gone out of your way outside of your job, for example, to interview myself in the F1 training and all of the different stages. So I think you're doing such a huge you're making, I think, orthopedic surgery, all of those things, a lot more accessible. You've also been like, I've loved the moments when we have been able to work together, or even like all of the other people in the department as well, where it's just been all about that learning. And I guess what I want to say is just keep up what you're doing as well, man. I think a lot of people are really benefiting from what you're doing.
Thanks, man. I appreciate that. And for everyone who's watching, I didn't pay him to say that at all. I just want to get that on record.
So when I send you my bank details afterwards, so it's all good.
Just send me a sort of code and bank account details, and I'll transfer you the money. But I really appreciate that. Thanks a lot, man. I appreciate it. But so if anyone wants to look at this interview in more detail, then go to my YouTube channel, which is Orthobuzz, or my Instagram, ortho.buzz, and I'll be doing more interviews as well. So next time we're going to be looking at the SHO grade and the kind of the next stage in training for orthopedics. So check that out. Thanks a lot, guys. Thank you, Janardhan. Take care. Have a good rest of the Easter weekend.
You too. Take care.
Take care. Bye-bye.